This is the final session for anybody attending of the Career Development Hub, and Tista and Marina will be talking about health inequalities and how to improve health in our communities. Thank you.
Welcome everyone. Shivani, can I just check, can you see my screen now at the moment, or?
Marina, so maybe if Marina stops sharing, and then just, yeah, that's fine.
Brilliant, okay. Fabulous. Right, so welcome everyone. I'm Tista, and I am joined today by Marina, and what we will do, I will start off for 15 minutes or so and then hand over to Marina. So the session today, we're going to be speaking with you about health inequalities, and I'm going to cover, as you might expect, the GMC perspective, so a regulator's role in addressing health inequalities, before Marina takes a more in-depth exploration at health inequalities in the round and the improvement policy around that. So that's our plan for today. But before we get started with all of that, just by way of brief introduction. So I'm Tista, and I've been in and around healthcare for about nearly 25 years, which is frankly terrifying. And I started by working, and still do, with survivors of abuse in sexual assault referral centres. And it was about 10 years ago that I also joined the GMC. And the reason for that, because people find that quite a, should we say, interesting career direction. But the reason for that is because I became interested in systems, as well as working directly with, in the SARC, we call them clients, but patients more broadly. So I'm going to share a patient story with you. Shivana has seen that with this particular story 20,000 times, but perhaps you haven't all. So I'm just going to share this with you, and it's a difficult story, as you might expect. So Talia, obviously I've changed details, but I met Talia 20 odd years ago, and she'd actually presented. We ended up seeing her in sexual assault referral services. And that was following rape from a partner. And as we spoke with her, a number of things came out. Ongoing domestic abuse. And where she was at, she didn't have much support at all, as you might imagine. And some of the sort of red flags that you'd be thinking about and wanting to be exploring with Talia, her where she was at that time, she was absolutely adamant that she didn't want to access other support services. She didn't want to escalate to police, or indeed safeguarding, or social services as we refer to it then. She didn't want to involve her GP. And when it came to her HIV diagnosis, she didn't want her partner to know. So very, very complex scenario. We were ultimately able to help Talia, just for your awareness, through multidisciplinary team working. And we were able to get to a safe house and eventually do all the things that you would want to in this scenario, working over a period of months. But it was her background that really got me. And I'll tell you, this is how, as I say, she presented. But what if I told you that as we learned more, we learned that she had reported sexual assault as a teenager. And that was with a huge amount of persuasion from the school nurse, actually, as it happens, because her background was, her home life was incredibly challenging, deprived community, lots of dysfunctional relationships, and yeah, she needed that support from school, and then she went to the police. The police asked for parental presence or parent or guardian to be there, which is massively erroneous. But Talia didn't know that at the time, so she didn't go back. And she was referred to counselling in the days when she did engage with the GP via the school nurse. So she was referred to group counselling, which she hadn't been expecting, but she tried, and it was all young people. But at one of the sessions, one of the young men, one of the teenage boys, young man there, referred to her as hot. So she didn't go back, obviously. Then she was referred to a psychiatrist. She didn't know, but the psychiatrist had the wrong notes. A male psychiatrist sat behind a big desk, and he asked her things like, do you remember your name? Do you know what date it is? Do you know what my name is? And Talia was terribly confused, terribly uncomfortable. And so she didn't go back. And then it was written down in her notes that she did not comply with treatment. And that, right back then, when Talia was 15, is when things really started to unravel for her. She ran away, and etc., etc. And it's that story which was a pretty shattering initial reflection of healthcare services and working in healthcare services that made me think we could have helped her years ago. Way back then in the 80s, we could have helped her, but the system just wasn't there for her. And that is what got me interested in systems as well as working directly with patients on the ground. So that is, I guess, that, as I say, that's an introduction to why I've chosen a sort of two-track approach to what I do. And I think it is very relevant that regulators are in this space. And I've got a question for you to get us thinking, first of all. Can you think of 3 or 4 things? And we've got Slido here. Shivani, can you launch the question, please? Thank you. So yeah, can you think about 3 or 4 things in the last 18 months? So they can be news stories or events that for you, really demonstrate health inequalities broadly that we have in the UK. So just start typing in news stories, scandals, events that all show health inequalities. I'll give you a few moments. I can see some people are here. Okay. COVID, absolutely. Long waiting times, yeah, that can be relevant. BME, COVID, yes, black minority and minority ethnic communities and the impact, the disproportionate impact of COVID. Any other news stories come to mind? Test and Trace app. So we're getting some thoughts in there. Give it a few more moments and see if anything else comes up. I think COVID is a big one, isn't it? Things like pay rises, absolutely. There are myriad inequalities, and today we're going to be talking about that which affects our patients and the public and professionals. So absolutely, races, and I'm going to cover that. Anything else? Okay. Right, so moving on then, these are some of the ones that I'm aware of. Structural racism. And we talked to a number of you mentioned COVID. And then what about maternity? You will have heard of all of the maternity, the maternity scandal, and I'll come back to that. And it's also worth noting that that disproportionately affects minority ethnic women. Rape. You will have seen in the news the shocking stories and the way that the system does not support survivors. And domestic abuse. Huge, huge health inequalities. And some of the reports around that you might be aware of over this last period, 18 months or so, you may be aware of the Cumberledge report around divisive things such as mesh, women not being listened to. I mentioned maternity. The Ockenden review is incredibly important, albeit harrowing reading. And something else, it's less so in that, well, it's gained traction in the last 18 months, but it's been drowned out perhaps by all of the other health inequalities that we see. But one thing that, again, interests me in particular is the way that the female phenotype is not studied, and autism is a good example of that. And we're hearing about more and more late diagnosis of autism in women, because it's, well, as I say, when the phenotype isn't studied, we don't know. The climate is changing around a number of these issues, and these are some, as you'll see from the dates of publication, the data around women, for example, is something that is being looked at more. And this is just one of the many tweets around these topics, but this is really positive. I'll just let you read the tweet rather than the detail there. Looking at gender equity principles in research. That's kind of fundamental, but we've not historically done it. And then moving to the huge inequalities we see across minority ethnic care. And this is a medical student having to create a handbook of clinical signs. And there's impact on professionals as well. And you mentioned racism, and we'll come back to that in a bit more detail. But in terms of impact on professionals, we've talked about sexism, we've talked about racism. Some of you might be aware of the Look Like a Surgeon movement, and the number of times you see and hear about women, female doctors, and it's assumed that they are the nurse or they are spoken to differently. Never mind, we've written a piece recently on inappropriate sexual behaviour towards female colleagues as well. And you'll see that on our website. But there are huge, huge issues there, but there are movements too. And then racism in medicine. So this is a seminal piece from the BMJ, and I would really recommend you read it if you're not aware of it, special edition. So whether we are talking about members of the public and some of the issues that we've just gone through there, or whether we are talking about professionals, clearly regulators have a role to play here. And this brings me to that point that was made, shall we say, in the poll chat there in the Slido. Employers make more complaints about minority ethnic doctors. And I'll just run through this graphic with you, just because I know it's a little bit busy. And I'm going to focus first of all on place of primary medical qualification, just because the data there are a little bit more robust. But suffice to say, unfortunately, it's an issue around ethnicity in and of itself as well. So the public complain broadly in line with the register. Okay, so this is broadly the makeup of the register. We've had about 25% international medical graduates for decades now, around about 10% European, etc. Member of the public complaints, 9% meet GMC thresholds, so they don't go anywhere mostly, because they might be about broader things like waiting lists, etc. and should be dealt with locally. Employers, well, that disparity there is huge, isn't it? Huge. And employers, as you would expect, know thresholds, whether we're talking about the GMC, whether we're talking about the Nursing and Midwifery Council, of course, they know thresholds. And with our minority ethnic colleagues twice as likely to be referred to the GMC, that means they are much more likely to be in the sharp end of fitness to practice. So yeah, there are thousands of complaints that are closed straight away because they're not for us. But the ones that meet our thresholds are massively overrepresented in terms of minority ethnic colleagues. And that is a huge issue. As I say, ethnicity, we know it's relevant there. Ethnicity as a factor alone is relevant, but the data aren't quite as robust. So with that in mind, given that our role as a regulator is to work with doctors to protect patients, to prevent harm, our role has to involve targeting inequality. And there are a number of ways that we do that. So engaging with doctors, students on the ground to hear what is happening in reality, whether it is working with an array of communities around big issues around inequality, along with our doctors, along with our medical students, whether it is promoting research, and Marina's going to go into this more, because our clinicians need to be involved in research to tackle inequalities. And whether it is most recently, some of you may be aware that we've set targets on addressing that disproportionate, the disproportionate referrals that come into us, because that is a huge problem, as I say. And it's a really, really tricky one, because we can't control what comes into us, and anything, of course, needs investigating. But they're coming into us, we're receiving them, and that means, in our view, we need to, at the very least, influence what comes in. And we've only got a short amount of time today, and I'm going to hand over to Marina in a moment, but this is a huge, huge issue, and there have been some great sessions that have explored this today, and I'm really, really happy to discuss this more offline, because we spend whole workshops looking at this issue around what we need to do as a system, because we can't tackle this alone. And unfortunately, receiving such disproportionate referrals, seeing disproportionality in education is something that the whole system needs to work together to tackle. And where I think we are now is that the rhetoric is moved from rhetoric to really good work that is ongoing. So some of you may be aware of the Medical Workforce Race Equality Standard, where we're working closely with Anton Emmanuel, with Marla Rao on these issues to provide early support. And my hope is that working together, whether we are talking about the public, whether we are talking about professionals, we can manage some of the myths, but the most important thing is tackle health inequalities together. So that's my view of where we should be from a regulatory perspective. And I will hand over to Marina.
Thank you very much, Tista, for such a brilliant presentation that's really very case-based. We could all connect with that on a very personal level. Hello, everyone who's joining us. If you have access to the chat box, do people want to introduce themselves, please, in the chat box? If you tell us your name and where you are in your career or your interests, it would be nice to connect to connect with all of those in our conversations this afternoon. My Twitter handle is at Marina Soltan _ and Tista's is at TC-Gannon. We would love it if you followed us on Twitter and really kept up the discussions going both during the event and after the event. So thank you very much for joining us, and it's a pleasure to be able to talk to you this afternoon. I'm just going to share my screen, and you will notice my desktop is very messy, but I hope it's coming through okay. Has that come through okay? Can you see my presentation?
Yeah.
Great, thank you. So this afternoon, I'm going to talk to you a bit about tackling health inequalities through data research and innovation. My background is I'm a clinical academic clinician in respiratory medicine, and I have been appointed now as the NHS England and Improvement National Policy and Delivery Lead for health inequalities, data and research. And that's what we're really keen to do on a national level, is to look at the data that we have, undertake research to explore where we have some of the widest system gaps, and then undertake innovation that builds system capability across England through all of the ICSs that we have to support systems and people with the tools and interventions they need to minimise and narrow the gap. So what are health inequalities? Health inequalities, they're unfair and avoidable differences in health across the population and between different groups in society. And they arise because of the conditions in which we are born, we grow, we live, we work, or we age. And the conditions we know influence our opportunities for good health. They might influence whether or not, if we became unwell, we would require admission to intensive care, or whether we would survive an admission or not. And they can also affect how we feel, how we think, how we act. So health inequalities, in summary, unfair and avoidable differences in health across the population and between different groups in society. We don't fully understand exactly why they arise, but that's what we're keen to understand in more detail. And they can affect our physical and mental well-being. And so Michael Marmot first started describing the concept in 2010 when he did a review looking at health inequality specifically, called Fair Society, Healthy Lives, which you can Google. What that shows in summary is a significant health inequality, primarily between the north and the south of the country, with significant differences in poverty, and significant differences in the environment within which people are exposed to and their health and health outcomes. And he did a re-audit in 2020, a few weeks before the COVID-19 pandemic blew out. And what he found, I'm afraid, was that 10 years on, some of our gaps, instead of narrowing those gaps, we've widened some of those gaps. And 10 years on, our health inequalities, which is that difference between the most deprived and the least deprived areas, is much wider. And when we talk about deprivation, in the UK, deprivation is measured using the Index of Multiple Deprivation score. Essentially, every postcode in the UK is associated with an Index of Multiple Deprivation score, and that varies between 1 and 10. So if you're number 1, you are within the 10% most deprived postcodes in the country, and if you have an Index of Multiple Deprivation score of 10, you're within the 10% least deprived postcodes in the country, and so on and so forth in between. So you might be asking, well, what is deprivation? So how do they measure deprivation? And they do that using 7 subdomains. So you've got barriers to housing and services, living environment, education, health and disability, crime, income, and unemployment. So for each one of these 7 domains, there is a calculation that is taken into consideration. So, for example, for barriers to housing and services, we look at housing quality. So, do houses have a significant amount of mold, for example? Are they structurally sound? Are they healthy houses? Is there a high degree of homelessness? All of these things would be factored into the barriers to housing and services. Living environment includes outdoor living environment and indoor living environment. So outdoor includes air pollution and road traffic accidents. Indoor includes, again, housing measures of housing quality. Education and training looks specifically at the average level of education. So, for example, whether you complete GCSE, A-level, a primary degree, or a secondary degree, so an undergraduate or a postgraduate degree, that's all factored into adult skills within education. And there's a children and young people's domain, which looks specifically at Key Stage 2, English, maths, and functional skills abilities. Health and disability is what it says, health and disability. Crime, again, is very straightforward. Income looks at the income that residents in that area would receive, and employment and unemployment, again, is very similar. So each of the ones at the bottom, each of these four subdomains, each of these four domains, they are standalone domains, but the ones on the top, they each have two further subdomains, and all of that information and data is pulled together, and it is unequally weighted to give you the overall index of multiple deprivation score. So crime contributes 9% to the score, whereas some of these other domains can contribute 20 or 22% towards the score. So it's well worth looking at not just the score, but the individual components that pull together the score. Because, for example, you might find that overall you have a score of 1, which is that you live in the 10% most deprived postcode, but that doesn't necessarily mean that every single one within your within the domains would contribute to a 1. So it's possible that you might, for example, be 5 for education, but perhaps if education doesn't weigh as much as some of the other ones, it's possible that that might sway your score. So if you've got a couple of subdomains here, for example, I've seen places where the income and unemployment, because they weigh quite substantially, if they're both 1, then despite the fact that your other domains might not be 1, your overall index is swayed towards a 1. But of course, it's a relative measure. So the overall index of multiple deprivation, it's a relative measure in comparison to the rest of the country, taking into account lots of different factors and types of deprivation. And when we talk about deprivation and when we talk about the gap, or health inequalities, we are talking about the gap between the most deprived and least deprived. And this is a map of England showing all of the different colours across the chloropleth map. So our red areas, those are the 10% most deprived postcodes. Our darker green are the 10% least deprived postcodes. And what you will notice is that we tend to see more deprivation in very inner cities, for example, here in London, and some of the coastal regions. We tend to see quite a lot of deprivation that relates to employment and employment opportunities, again, income and educational opportunities. A lot of this is historic, and it's quite interesting when you go back and look at the history, particularly up in the north, around the Industrial Revolution, the ports, and opportunities as they have evolved. So that's an explanation of the index of multiple deprivation. And some of our green leafy suburbs, so for example, Solihull and the Cotswolds, for example, those will be in the 9 or 10 region. They're not inner city regions, they're not coastal regions, but they're leafy suburbs, and so they tend to be less deprived. And this is an example of a map on a smaller scale. So Birmingham, this is a map of Birmingham. And again, Birmingham is not a coastal area, so we're not that privileged in Birmingham. But what we can see is that in the inner city areas, we've got the most deprived regions. And as you move away from the inner city area into those leafy suburbs, we see lower levels of deprivation. Now, health inequalities, I think it's important to mention that these predate COVID-19. Shone a light on health inequalities, and I'm going to talk in detail about COVID-19 later on, but I just want to highlight the national picture beyond COVID-19. So this is from Michael Marmot's first report from 2010. These are the policy aims that Michael Marmot suggested we should implement to try and reduce the gap. So he suggested we should give every child the best start in life. We should enable all children and young people and adults to maximise their ability to look after themselves, create fair employment and good work for all, ensure a healthy standard of living for everybody, create and develop healthy places and sustainable communities. And again, that touches on the point around history that I was talking about. Strengthen the role and the impact of prevention of ill health. And those were Michael Marmot's 5 key policy objectives. And it was unfortunate that when we re-audited this 10 years on, it looked like we hadn't made as much progress as we would have liked in those areas. highlight a point, the effects of inequalities on health really does start from early years. And what's interesting is this is a graph from Public Health England that looks at childhood obesity in year 6 of primary school. The top line, the pink line, shows the trend from 2006 in the most deprived areas. That's clearly an upward trend. And the blue line is the least deprived areas. So those are the ones that have an index of multiple deprivation of 8, 9, or 10. And this is 1 and 2. And what we can see is that in the least deprived areas, we're actually luckily seeing reduction in obesity over that period of time, and already a lower baseline to start with. So in 2016-17, which is our latest data round for childhood obesity, we can see a significant gap that has grown when it comes to childhood obesity in year 6. And we have to remember that this is the prediction of the future. So our year 6 pupils in 2017, in 10 years' time, that's going to become our young adult generation. And we know that childhood obesity is associated with multimorbidity, ill health, and suffering from chronic disease, as well as an increased risk of admission with acute illness. So this is really an important marker, which is statistically powered, and is an indication of deprivation. And when we think that Sir Michael Marmot identified that giving every child the best start in life was an important policy objective, this is really an indication of how much we haven't yet managed to achieve that. So this is an important slide when it comes to policymakers thinking about how do we tackle childhood obesity, how do we minimize the effects of this in the future. And the statistics are quite stark. So I'm just going to run through the next few slides on the data nationally about health inequalities. So between the least deprived and the most deprived deciles, there is 15 years difference of life expectancy. Can you imagine? So if you live in some of the most deprived areas in the UK, you will live on average for 15 years younger, 15 years less than if you live in the least deprived areas. And when we think that, for example, NICE, the National Institute for Clinical Excellence, have committees which evaluate medicines based on their ability to extend life by as little as 3 months, then 15 years of life expectancy that's lost due to deprivation is a shocking statistic. And that's not just for males, it's the same for females as well. And this graph is a very nice graph from Public Health England that really does show the differences in life expectancy between the least deprived areas and the most deprived areas. And again, we can see here that you're effectively living for a shorter lifespan if you live in the most deprived areas compared to the least deprived areas. And this graph from Public Health England shows, again, that people living in the most deprived areas, they have a shorter, healthy life expectancy. We can see that in the north, there is effectively a shorter than average life expectancy, whereas in the south, we have a longer than average life expectancy. So we started to look at what is the breakdown of life expectancy inequality, what contributes to this gap that we're seeing, this life expectancy gap. And interestingly, the key contributors are cardiovascular disease, chronic respiratory disease, stroke, which I think fits with cardiovascular disease, influenza and pneumonia, cancer care. So our key ones being very much cardiovascular disease, chronic respiratory disease, and cancers of varying types. This is a nice scarf chart from Public Health England that shows that data quite nicely. Cardiovascular disease, cancer, and chronic respiratory disease, the 3 biggest causes and contributors to this gap. And I wanted to include this graph because it shows you that in the most deprived areas, we see the highest mortality from cancer in comparison to all other areas of deprivation. This is really stark data that if you've got cancer and you live in the most deprived areas, you are less likely to survive than in the least deprived areas. And some of the interventions we're looking at is how do we increase our early diagnosis of cancer in some of these most deprived areas so that people present at much earlier stages in the disease process so that we're able to improve outcomes. And some of that relates to screening. I'm going to talk about screening a bit later on. On chronic respiratory disease, what we've seen over the last few years is a year-on-year increase in admissions to hospital and a year-on-year increase in mortality from chronic respiratory disease, a year-on-year increase in admissions to hospital from chronic respiratory disease, and a year-on-year increase in readmissions to hospital from chronic respiratory disease. Acute respiratory disease. And when we talk about chronic respiratory disease, we are ultimately talking about asthma and COPD. And when it comes to asthma, I'm going to show you this graph. And if you look at the UK in relation to the world, so red is the highest prevalence. And when I click on the graph, you will be able to see for the last 30 years, the prevalence of asthma in the world. So if we focus on the UK, for 30 years, we have had some of the highest asthma prevalence rates in the world. We are still red. That's a shocking statistic. And this graph shows us where the UK is in relation to every country in the world when it comes to asthma prevalence. So it's not surprising that we're seeing such a stark inequality in the UK from chronic respiratory. And we can see from the Nuffield Trust last year that it was found that in the UK, young people are let down on long-term illness. So children are much more likely to die in the UK from asthma in relation to other countries of a similar GDP to the UK. And when we talk about COPD, we can see that in the UK, we have some of the highest mortality in the whole of Europe. And within the UK, there's a stark health inequality between the north and the south of the country, with much higher percentage of patients with COPD in the north, and again, higher mortality in the north in relation to the south. So these are all constitute health inequalities, variations based purely on where people are geographically located. And interestingly, when we talk about severe mental illness, so we looked at the data for COPD and for asthma in patients with severe mental illness and in patients without severe mental illness. And interestingly, unsurprisingly, you will see that patients with severe mental illness are more populated in the most deprived areas. So that's another lens within which we have to consider the data. And again, in patients with asthma and COPD. There. Severe mental illness. So what are we doing to support those patients? And the NHS has launched the Severe Mental Illness Health Check, the annual health to look at why is uptake in some of these areas so. What can we do to shift this trend to a more even playing field? How do we level up to minimise the gap? And this slide, which I'm sorry isn't working, shows essentially that in the most deprived areas in our country, we have the highest acute admissions. These are real people living in communities where they're more likely to have chronic underlying disease. They're more likely to require admission for acute admissions due to underlying chronic disease. And there's an increased pressure on NHS services and an increased pressure on staff working in those communities. So how do we understand all of that? And what do we do as a system to address that? And I promised I would talk about screening earlier on. This graph, I really like this graph. This is screening for AAA. And what we see is in the most deprived areas, we have the highest disease incidence of triple aneurysms, but the lowest screening uptake. Whereas in the least deprived areas, where perhaps education is better and communication with services is better, we have the highest uptake of screening, but the lowest incidence of disease. And we really urgently need to shift this trend the other way around, because clearly we need to access our patients in the most deprived areas a lot better and support those patients to uptake screening services to prevent disease and acutely ill health. And perhaps some of the most stark statistics relates to maternity care. So we know that in the most deprived areas, there's a higher rate of preterm birth, which is correlated with maternal and neonatal mortality. And the Embrace report just couldn't be clearer. It shows that in the most deprived areas in the country, it shows that patients of Black, Caribbean and Asian ethnicity are more likely to die in terms of maternal mortality in comparison to white population. For example, Black Africans are 4 times as likely to die in comparison to white women. that's a shocking statistic. It's a deeply distressing statistic, and something that we need to act as a service to address. So when it comes to COVID-19 has only shone a light on health inequalities that were already there. So when we're talking about restoring services, which is one of the key priorities nationally, we need to think about restoring services to a new, better level than where we were before. And it's not surprising to anyone watching this presentation that in the most deprived areas of the country, we've seen the highest rates of COVID mortality. And we've also seen that in the most deprived areas, patients are more likely to be ethnic minorities in terms of population, and ethnic minorities have been disproportionately affected throughout the COVID-19 pandemic. Necessarily just due to their ethnicity, but they are more likely, the data does tell us that ethnic minorities are more likely to be populated in regions of higher geographical deprivation, where patients in those areas are more likely to have adverse outcomes from COVID-19. I'm going to show you a clip of myself talking to David Harewood on BBC One on why is COVID killing people of colour, where I'm talking about the research that I've done looking at the health inequalities in the context of COVID-19. Okay, that's not working, but I do have it later on in the presentation to show you shortly. So ethnic minority risk profile accounted for in our current clinical risk tools, and I'm pleased to say that the paper that I did looking at this was accepted for publication yesterday in BMJ Respiratory Open, and I will be able to share that with you in due course. It's currently out on preprint. But what the paper effectively finds is that ethnic minorities have younger age structures. So you can see here the average age in the UK of a white patient aged 41, whereas all other ethnic groups are much younger than that. Risk tools don't account for this differentiality in age structures. Ethnic minorities have higher multimorbidity despite being younger, and they're more likely to live in more deprived areas despite being young. And deprivation, we know patients who live in the most deprived areas, they're more likely to have higher multimorbidity. So they exhibit a risk profile that currently our clinical risk tools don't always account for. So that's something that I'm looking into, and I a degree looking at this in a bit more detail. So we need to understand the health impacts of the wider determinants of health for every patient. These are real patients, and their lives are being affected by what I'm describing as hidden risk factors. These are risk factors that patients are being exposed to on a daily and hourly basis, that when we see them in the clinical environment, we only see the patient in the clinical environment. We don't know where the patient has come from or what the other hidden risk factors are. And interestingly, we ask patients, do you smoke? But we don't ask patients at the moment, do you live in an area of high air pollution? Do you live in an area where income is an issue? Is income an issue for you? Is your house in good order? Do you have mold, household mold? These are real factors affecting patients' health, and they constitute factors of deprivation that currently we don't have a way of capturing adequately in hospitals. And the WHO is very clear about the dangers of some aspects of deprivation. Air pollution accounts for 8 months on average of life lost, and up to 2 years in the most polluted cities. Can you imagine? That's such a lot. That is such a significant period of life lost just due to air pollution. And socio-environmental factors, such as access to satisfactory housing, air quality, and work, are estimated to be responsible for about 13 to 20% of the disease burden in Europe. These are quite stark statistics, purely just from social determinants of health and air pollution. So I was keen to look at some of this in a bit more detail. I led on 2 research papers now, both of which have been published, which were based on the back of data from ICNARC, which suggested that 34% of critically ill COVID-19 patients in the UK were of ethnic minority, despite the fact that ethnic minorities only constitute 14% of the population. And the Office for National Statistics data, which highlighted that patients in the most deprived areas were twice as likely to die of COVID than of other causes. And I was really keen to look at this in a bit more detail by not just looking at the index of multiple deprivation, which is the overall index I showed you earlier, But I wanted to look at some of the sub-indices in a bit more detail. Because, for example, crime, which contributes about 9% of the index of multiple deprivation, probably isn't going to affect your outcome in terms of admission to ITU or an adverse hospitalized episode, unless, of course, there's lots of stabbings in your area. But in relation to COVID-19 outcomes, we were keen to start looking at some of these specific wider determinants of health, some of the specific hidden risk factors. Do they affect patients' admission to ITU or their outcomes? And that's what we're talking about here. So our first study looked at household overcrowding, air pollution, housing quality. To what factors modulate how patients present, whether or not they require admission to ITU and their outcomes. And then I went on from that paper to do a multi-center study looking at the effects of overcrowding, air pollution, housing quality, and adult skills deprivation. To what extent do they modulate presentation, admission to ITU, and outcomes among hospitalized patients? This time, because it's a larger study and we had larger N numbers, we were able to disaggregate the data by ethnic minority group and then ask a second question, looking at what is the current state of play when it comes to clinical risk tools. Do our clinical risk tools satisfactorily account for the different health inequalities data lenses?
I'm really sorry, Marina, but
and this is these are a couple of graphs that show the study population in relation to the local area, where it's quite similar.
Sorry, Marina.
Yeah.
Sorry, I'm really sorry, but I'm going to have to ask you to wrap up really soon. Unfortunately, it's all we have time for. Is that okay?
Yeah, that's brilliant. Thank you. Nearly done anyway. So what the study found was that patients admitted from regions of highest household overcrowding and highest living environment deprivation, they were more likely to present to hospital with multilobar pneumonia and more likely to have an adverse outcome from COVID-19. And that's what these graphs show here, ITU admission and mortality. And we did a cluster analysis to look at some of this in more detail, asking the question, is it the deprivation? Or is it, or is it the multi-morbidity? And what we found was that patients in the most deprived regions, irrespective of whether they died or whether they were discharged from hospital, these patients, they had the highest levels of comorbidity. So comorbidity ultimately is related to mortality, but of course, living in a deprived area predisposes your risk to exposure to comorbidity and multi-morbidity. So the work is available on Twitter and in 2 journals. It's been published now in 2 journals. This you will have seen some of it featured on BBC One in Why is COVID Killing People of Colour? So I will leave that for you to have a look on BBC One. And if anybody's got any questions, I'm more than happy to take some of those questions. And these studies have been cited by several parliamentary groups, including the DEFRA group and also the All-Party Parliamentary Group for Longevity. Any questions, I'd be more than happy to take them. And I will also leave my email address in the chat box so that if anybody wants to follow on, they can do. Thank you.
Great, thank you so much. There doesn't seem to be any questions at the moment, but of course, if anybody has questions, then definitely feel free to message Marina or Tista on their Twitter. Great, thank you both so much. It was such a valuable session today, and that's the end of the conference, really. So feel free to sort of go onto the main stage or onto the speaker lounge as well. And thank you so much once again.
Brilliant, thank you.
Thank you.